Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. Tonight is going to be Dr. Natasha Bartel bringing up the random topic, I guess. It seems like you had a rough week, so let's go with
it. We won't discuss my week on the podcast, but
we want, but we'll skip over that. But anyway, so what's the topic for tonight?
Because it's the February podcast with Valentine's Day, I thought we could talk about love or the lack thereof between me and most surgeons, JK. We're going to talk tonight about gastroprotectants and their role in anesthesia.
Oof.
Yeah.
Hell yeah. Is there like a fart sound?
Is there a sound of like a heart breaking somewhere? Like,
I don't have that yet. I need to find that.
Did you find a fart sound? Yeah.
Oh, so there probably is.
I think probably in the past 10 years, there has been more consideration given to peri-operative nausea and vomiting and some of the gastrointestinal side effects of anesthesia, which we don't really spend that much time, I think, considering. You know, there's always chit chat about things like cardiac output and oxygenation. Like, those are so important. But let's talk about things like nausea, ileus, diarrhea, vomiting, emesis, reflux, regurgitation. As we've become more cognizant of it, and a lot of this research comes from the very good team actually in Greece. They put a lot of these papers out. They're the ones who speak at the conferences. And, I hear the anesthesiologists, talking about protocols, and they're like, do gastroprotectants really change anything? How do we know if the animals, are actually feeling nausea or ileic? So first of all, just generally speaking, how do you guys feel about the use of, and I'm going to clarify for the listeners too. So gastroprotectants, it may include antacids, they may include antiemetics, they may include prokinetics. There's pH neutralizers like sodium citrate out there. So do we think that there's a valid role, first of all? And if so, which drugs are you guys selecting and why?
I'll jump on it.
Jumping at the bit.
Just because I will also say reflux, regurg are like the banes. Like, it feels like the bane of my existence. It's like the complication I truly hate the most. It's vile. It's disgusting. I feel like I immediately start to feel emotionally bad for the patient. I also am a person who suffers from post-op nausea and vomiting. So when I had anesthesia, I threw up for 2 hours. Or threw up for 24 hours every 2 hours. It was really neat. Super.
That must have been fun.
You are such a ninny. Okay.
I know. I was 18, really at the height of my strength.
But are we allowed to know what you were being anesthetized
for? My wisdom teeth. Very exciting. I know.
I know.
Was it even worth it?
I know. I threw up on the doctor, reportedly. Which I'm like,
what did you get?
Was it the dentist? Because I don't really like dentists. I'm okay with that.
I think fentanyl, midazolam, and I'm assuming inhalant. I'm pretty sure there was inhalant involved.
This is why I love the difference between US dentists and European dentists. They just fucking held me down on the chair. They don't care. I had it awake. I had the whole thing done awake.
Mine were all impacted, not to drill all this bone and shit.
They must have given you a local block.
No, a local block. It was fine, but they don't even
But you're still biting on a leather strap. That seems a little ridiculous.
They're so. Fun fact: when I had a root canal in the past done in Italy, and the first time they did the block, they got like 2 roots out of 3. And at the third one, I was still feeling. They're like, okay, this is super inflamed. Probably, we just send you home with NSAIDs for a week and then come back. It's probably just because of, the acidic pH. The block is not like working as it should. I was like, all right, sure. I go back and it didn't hurt as much, but it did hurt. And literally the guy was with his knee on my chest while it was fucking drilling down on my tooth. And I was
Here is never go to a dentist in Italy, obviously.
Yeah.
I just like that story a lot. I really have a low tolerance for mouth pain, probably due to the highest concentration in the body of substance P, which is a known nociceptive neurotransmitter. But that's
okay,
When when I saw them do a root canal in a dog when I was a veterinary dentist, I'd never seen one because like dentistry was not my cup of tea as a student. And I was like, when they put the drill into the root, I was like, what? Is that what you do? It blew my mind. It was like this thing, and it was like zoom, and I was like, whoa. I
yeah.
was like, wow, dentistry, they're really miles ahead of everything. Anyway.
Yeah, the old hit him over the head and just yank it out.
Yeah, I was like, why don't we just rip these teeth out?
But really, back to your point too about like regurgitation and reflux. I will tell you this, that if I could pick a cause of fatality under anesthesia in my own like patient population of patients that I have anesthetized over the last bajillion years, I will tell you that if I'm going to lose something acutely, right, in an absolute like just like horror show blaze of glory, it will be because they aspirate.
Yep. Oh,
right?
yeah, for sure. That's like death sentence.
The vast majority of patients who reflux do not regurgitate.
Yep.
And so the listeners know the difference is do the gastric contents enter the esophagus or do they enter the oropharynx? Most of it is occult, which means it's not noticed by the anesthetist. And most of the time, even when you do regurgitate fulminantly, you don't necessarily aspirate. But let me tell you, when you do aspirate, especially if you're a cat, it's a total nightmare. And I had this shit case once where the dog had an entrapped like hiatal hernia and it actually caused like a ring of necrosis. And when it relaxed from induction and got released, it spewed like 2 liters of black fluid. And the mistake that I had is I had intubated, I had inflated the tube, I secured the tube, and I had not connected the tube to the breathing circuit. So it regurgitated and then it aspirated through its own endotracheal tube, making the aspiration both faster and more efficient and bringing death so much more quickly. So ever since then, like anytime someone intubates for something where I think like, dystocias, GDVs, foreign bodies, like I think you're going to regurgitate, I'm like, connect the circuit. And then I do this horrible story where the dog basically aspirated through its own tube and it was dead in 90 seconds. And there was honestly nothing I could do. So I hate reflux and regurgitation
I hate it
as well.
It also is smelly and it's gross, and you have to like flush and suction their esophagus, and you got to wear gloves because I don't want that regurg on my hands. And then they're like you do the TBLO, they regurg at induction, they regurg shortly after induction, and then it's like, well, here we go, we're gonna be regurging all day, and it's just like such a challenge. So anyway, I hate regurg. I hate it all. I wish there was a silver bullet. I know there's not. I'm not dumb enough to know that. They're not dumb enough to not know that. Yeah, I do use gastroprotectants in patients who, and this is actually a very timely topic because we have been out of methadone in my clinic. So we've had to use hydro, and we've had a lot more regurg in just 1 week. And I'm like, goddamn hydro. But I do use gastroprotectants. I personally like maropitant and Pepcid. I choose Pepcid as a veterinary anesthesiologist because it's, from what I remember, it works the fastest. It may not have the most reduction in gastric pH, but it supposedly works faster than something like omeprazole. I'll tell you, my personal cat, when she got anesthesia, she also has like probably underlying IBD that I'm not treating, but she's relatively fine. She got she just throws up. She has like
shoes. Like the shoemaker's kids never have their own shoes, right? Like
she just throws up 1 day a month. She throws up a bunch. We take her food away. She gets her food the next day. She's perfectly fine.
You
She
should
doesn't
edit
get
that part out.
what's that?
Edit the part out where Bailey doesn't treat his own cat. Get rid
No,
of
she's fine. She gets her HA. She doesn't get anything that's not her food. She does great now. She got famotidine and Serenia the night before and the day of her procedure, just to decrease the chance she would have any sort of like GI upset following anesthesia. I think we are really lax in the way we treat the GI. Like in a human, you have to fart to even leave the hospital, and we're like, who cares? Dog hasn't pooped in days. Send him home.
Yeah. I
And
mean,
Beanie, what do you think? Like, is it
so I mean, again,
high on your radar of concern, or?
it is. It is. Although, I mean, I'm very well aware that there's no there is no silver bullet here, and unfortunately, well, so I think we need to differentiate a little bit, right? If you have a patient where you're concerned, like your general patient that you're putting under anesthesia, and you're worried about regurgitation and aspiration, it may happen in a couple of different scenarios, right? So if it happens when the patient is regaining consciousness or it is conscious post-op, that is usually mostly due to the inhalants, right? A lot of people do not realize that, but P on V is mostly due to inhalants, right? It's not due to opioids. People link it to opioids. In reality, the puking that you're seeing with opioids is mostly the pre-op one that you see.
And also,
There
I'm just
is
going to
some,
put it to listeners, like opioids too. Like you're more likely to see like nausea and vomiting, depending on whether they're hydrophilic or lipophilic. And also, generally speaking, if you administer an opioid, especially a full mu, to a patient who's non-painful, you're more likely to see the GI side effects that we're hoping not to see. But if you have a patient who has bilateral fractured femurs and you put them on fentanyl, that patient won't barf, right? Like that patient doesn't barf. And that just
right,
basically has
right,
to do with like receptor expression and binding. But yeah, like if
right.
you get, that's why I hate when people are like, well, we're going to sedate it for x-rays. It's not really painful, but we're going to give it hydro. And I'm like, don't do that.
Right.
Why would
It's
you do
not
that?
painful.
Yeah,
It's
no,
not indicated. It will vomit.
Yeah.
So
absolutely, right. And usually, again, as you said, the patient is not needing opioids. In the post-op period, you rarely see, I think we rarely see nausea from the opioids, unless you give crap ton of it, and then that's totally your fault. There's no way around it, right? Like that's, you know,
you're
if you
just
do
bad, you're
that,
bad at
that's
your
silly.
job. You're bad at your job.
No, but you need to be aware that, pain scoring your patient and guiding your pain relief based on pain score, it's probably the best way to do it. And that's the best way to avoid overdosing your patients with opioids, right? Not every patient needs crap ton of opioids post-op, right?
I
Some,
wonder
and
who said
also
that. I wonder who wrote that. Hmm.
Here we go.
right?
It's you. You're the one who did
Here we go.
But
that paper.
anyway,
Your paper. It's really good. It says that if you like don't pain score your dogs and you just annihilate them with methadone Q 6 hours, they don't eat. They're reported more as painful. They are like nauseous. They vomit.
100%, 100%. And and that's really, it's really true. So I think you need to differentiate a little bit, right? Like if you're talking about nausea, you need to target it with drugs that are targeting nausea, right? So those are your maropitant, those are your ondansetron,
Yeah.
which I really like too, right? Like ondansetron is a really good drug, and some people, they're not aware of it being potentially used in veterinary medicine, right? Like we use it all the time.
Yeah, me too.
When it comes down to your acid reducers, I think they're a double-edged sword, right? Like, so if your patient aspirates after the pH, at higher pH stomach content will get, at least there are studies that show that they will get a worse aspiration pneumonia compared to a more acidic content. And that's because, of course, what stops bacterial growth in the stomach content is acid, right? So
But
there is,
Beanie, I'm just going to qualify that. Like, what weren't the papers that looked at patients who aspirated on neutralized stomach pH? Those were like long-term ventilator patients, right? So like, and they had received repeated dosing. So like those were human patients being ventilated long-term. That wasn't like one-off veterinary GAs for 3 hours where we treat with half a mg per kg of famotidine. So I generally
No, I agree with you.
I don't
But
worry about the GI pH neutralization because it's not protracted enough to where I think where you're actually going to have an issue in
unless
terms
your
of
patient comes in with it.
well,
Like if
that's
you have a
different.
patient that is
If you're
if you
on
have a
like
patient that is on it long term, then you're it.
and honestly,
Also,
the worst offenders for those are going to be usually like mast cell tumor patients, right? Because they're on
right,
H1 plus or minus H2 blockers. Just
correct.
listeners, you realize there's a multitude of histamine receptors. So that means that even if you have a mast cell tumor and you only block, for example, like H1 with diphenhydramine, it can still degranulate and cause an allergic
Stomach
and
ulcers.
anaphylactic. Yeah, it's like you'll still get a reaction. So when you're blocking for mast cells, try to block as many of the histamine receptors as you can. But I find the mast cell ones are usually the ones who've come in on like the long-term GI stuff, mostly because medicine, they tend to give omeprazole these days, right? Like, there are awake papers
Now,
studied which ones were more efficacious, and it did show that like the proton pump inhibitors are better than the histamine blockers. But I also remind them when I get this lecture from internists that was not the same finding of patients under anesthesia and that the dynamics are different. So we can't take awake rules and apply them to anesthetized rules. But yeah.
There's also a time
now
component too, because I think omeprazole takes a lot longer to work,
3 days.
and so in our
Isn't it
patients,
24 hours, right? Like if you do omeprazole, Panto is faster IV, right? But
Pando is faster IV. Omeprazole takes up to 3 days to actually work.
yeah,
that like the papers where we compared like anesthetized gastric pH between famotidine, ranitidine versus pantoprazole, it was kind of
yeah.
a big deal, right?
Now let me throw a wrench into your thoughts.
You do that.
Now, when you have a patient that comes in omeprazole long term, right? You had a patient that's been on it for like 2 weeks or 3 weeks and whatnot. Do you ask for repeat blood work?
No, because I find that like the electrolytes imbalances associated with proton pump inhibitors, that comes after like months of treatment. If not, like there's a cap on how long you're supposed to prescribe omeprazole, right? It's like a year. Because it can leach
What if I
calcium,
told you,
it can leach calcium and disrupt magnesium. So, like if you've been on it for a month, I probably don't care that much, but I'm probably going to have baseline electrolytes anyway. So
what if
it's
I
a
told you
bullshit
that
answer.
most gastroenterologists in humans, they won't give it to you anymore for more than 3 weeks?
Wow,
Okay.
And
interesting.
the reason is there is newer evidence that show that actually proton pump inhibitors do cause interstitial nephritis, which can lead to AKI and then CKD.
Yeah, I know because my doctor put me on pantoprazole mostly for being an anesthesiologist, and she made it clear like I had to do urine and renal
Sorry.
panel. Yeah, it's like it's funny that because I just took my panto right before this call. But it also like they've shown too like there was a weird thing about omeprazole like contributing to idiopathic like severe hip pain. Right? Because like my mom has been on omeprazole for like 592 years. And at some point I was like, hold on, Margaret, like we need to like talk about this and like get your doctor to like revise this. I don't think you've been back for a recheck, but you're not supposed to be on omeprazole for 4 years. And like she's always complaining about her hip. And so I actually found this
So
like in the insert in the package, like idiopathic hip pain, idiopathic back pain. Whether or not that's related to disruption of calcium metabolism, I don't know. But I was
no.
like, hello, Margaret. We're like coming off this drug. Shout out to Margaret.
Yeah. It's
She'll be like, don't mention me. Shut up. Boy.
anyway.
But yeah,
Yeah.
I mean,
So I don't know, like, I was on it for a while because I've GERD, right? And
another anesthesiologist on an antacid. What a shocker.
yes, and now they flipped me. I mean, they've been for a while. They put me on famotidine rather than omeprazole because they were like, we cannot give it to you for more than 3 weeks because of the risk of interstitial nephritis and whatnot. Like, and actually, it seems like most people do get the interstitial nephritis, whether it evolves to AKI, it's due to other factors, maybe like, genetics or whatnot. But it seems like the inflammation it's definitely caused, but whether it evolves to damage It's
After I
amazing.
just took my Panto, this conversation is making me super anxious, and I might have to progress to a diaper next. Like, this is not a reassuring chat, guys.
You started it.
Yeah, this was your choice. I'll
This was
remind you.
totally your choice.
Yeah. Well,
GI meds,
let's
the
get away. My
worst.
Panto is going to kill me later today from renal failure because I'm starting to sweat
Nice.
in weird places.
So maybe we shouldn't put all our patients on all these GI
Probably not.
meds.
Well, yeah. Okay. So
Probably
here's one,
not.
guys. How do you feel about a single dose of metoclopramide pre-anesthetically? Side note, I hate it.
Based on the papers, I think it's a good idea.
A good idea?
You think it
Yeah,
is or
based
it's
on the
not?
evidence, 0.2 mgs per kg sub-Q decreased nausea and vomiting in patients
What
that they
paper is
looked
this,
at.
Bailey? I don't think I've read this paper because all the papers subsequently showed you had to have a metoclopramide CRI at neurotoxic dose.
I'm not talking about regurg. I'm talking about patients that they
Yeah.
looked at and assessed for nausea and vomiting, and they reported the patients were listed. So nausea is a qualitative or a qualitative. It's a qualitative characteristic, right? It's I think this patient's nauseous. Whether animals can experience
Subjective,
nausea or not is up
maybe.
for debate, whatever. I'm not going to go there today. But there was a paper, and I can send you the citation after this phone call.
I'd appreciate it.
It was like 0.2 mgs per kg of metoclopramide sub Q, and it
Yeah.
decreased nausea and vomiting. So, like in patients where I do think it's a risk, I think that's a really reasonable idea.
Yeah, but people used to give the metoclopramide not for nausea and vomiting, but
Yes,
specifically to promote gastric emptying, right?
that's all hogwash.
Also, quote, air quotes, for if you can't see me, I'm air quoting, is to prevent reflux regurgitation. And for sure, like the motility component, you have to be on that neurotoxic CRI for it, right? Like
Yep.
that's pretty
Oh yeah,
consistent.
100%.
Honestly, don't forget that metoclopramide can be unbound by the anticholinergics. So my question is how beneficial is it? Because almost every patient pretty much ends up getting atropine or glyco. And then it's going to get bounced off anyway by the anticholinergic at the muscarinic receptor. So why bother?
Most of
Especially when I
your
can give
patients get
ondansetron or Serenia.
Right.
most
Okay.
I
of
think
your patients get an anticholinergic. Mine's not.
true.
Well, Beanie,
I'm kidding.
okay.
I'm kidding.
Fuck you, yeah.
Okay, whatever.
Like it's not a drug I'm using on a de rigueur basis, but it is something I would keep in my arsenal of tricks that you break out once in a while. Yeah.
Fair enough. I think that's fair. I also get concerned about like really chronic metoclopramide CRIs because when they are awake, there is a prokinetic effect. And I don't know if you guys have ever traveled, but ileus, which is obviously can make you quite nauseous,
Yeah.
but also being prokinetic is very uncomfortable. Like it's crampy and makes you poop your pants.
Yep.
And you also get nauseous from that too. And sometimes what I've done is patients who've been on like a day or two of metoclopramide and they're not eating, I stop the metoclopramide, and then after a few hours, they eat again. And I think it's because that, and it's diarrhea, it's not eating. And I'm like, well, first of all, you need to turn your fentanyl down from 1 billion. And second of all, stop the metoclopramide because that prokinetic effect, I think, can clinically end up being quite detrimental. So,
Yeah.
yeah,
No, I
it's
agree
not
with you.
let's put it this way. It's not my favorite tool in the toolbox.
No, I wouldn't say like I'm not using that metoclopramide sub Q as like a routine thing, but is something that I, think about from time to time for
Yeah.
some select patients,
Because it
really.
always
It's
used
a
to
good
be like
option.
every bulldog under the sun had to have metoclopramide to like
Yeah.
rock out on anesthesia.
Oh yeah.
I know that still goes on. And more specifically, I know it's still taught in some of the vet schools. And it kind of makes me want to, take another pantoprazole until I learned that it was going to cause renal failure. So,
Yeah, I found it some like
okay. I mean, do you think that our patients suffer from nausea?
I think they do. I told you I'm not going to get into it. I think they do, but
No, you
I
have to get into it. That's the point of the podcast.
I don't know enough about nausea to be like, well, based on the brain and the nausea, and blah, blah, blah. Like, yeah, they're like smacking their lips. They look like they're gonna yak. The patient's like, I can tell when my cat's gonna throw up because she starts doing this.
And they start making that noise, like the
No,
like,
before
oh
that,
my
she'll
God.
sit in my lap and she'll be like licking her lips constantly, which is what I do when I'm about to throw up. I'm like, oh yeah, I can tell I'm gonna vomit
I
shortly.
mean,
Yeah. Yeah, I
I
think
can
they
tell
do.
you
And I
that.
think the histopathological staining studies have shown like there's a really similar pathway, like the pain, the itch, and the nausea pathways are really, really like
Sure.
physiologically similar and closely
Yeah.
related. And like when they've done the histopathological staining in dogs, they've actually shown that they have like the same pathway, the same receptor. So there is some good data or evidence that's looked at this, especially because they use dogs all the time for human studies. So, you know, and I think clinically, you know, you see the patient have like prodromal signs and then they vomit. So I think that's consistent with nausea. And I have a
Oh,
high
yeah.
degree of concern because personally, I don't know about you gentlemen, but if I had a choice between like a high degree of pain and a high degree of nausea, I would take the pain. I find I'm so intolerant towards nausea. Like I hate it I just hate it. And I just like, you know, if I get a migraine, like the pounding is one thing, but once I become nauseous, I'm basically incapacitated.
Yeah.
Yeah, no, I agree.
Yep.
I mean, I think again, I mean, I think the metoclopramide is definitely a good option. I usually reach out for like maropitant and ondansetron before I do metoclopramide,
Yeah.
and I usually give them together. I can tell you that you know, to be honest with you, all these patients that I already know that potentially are going to be nauseous and whatnot, like you know, brachycephalics, and I just throw them on Diva. Like, why would I make it worse with fucking gases?
No,
Back
I mean,
to Tiva.
now,
Hell yeah.
do you guys think like let's talk? Yeah, well, let's talk a little bit about Ativa and nausea because I want to address an urban myth about lidocaine and nausea. Thoughts, comments?
So I never seen it with the lidocaine, to be honest with you. Although during my residency, people did believe that that was a thing. I've never seen it, to be honest with you. Maybe I use it at not high enough doses to see that. Like you know, if you go at the Ontario Veterinary College, they do 200 micrograms per kg per minute of lidocaine, right? Like for the first hour, and then they decrease it and whatnot, which is fine. I mean, I get it. Their reasoning is try to get the sparing effect, try to get the you know analgesic side of things. Great. Maybe at those doses, yes, you may end up seeing the nausea, right? Like, and I have no clue. I didn't try it. I wasn't
That was my
ballsy enough.
understanding of wherever I read this 100 years ago. This is the problem: is like the longer this career goes on, the less I can remember my own references. But I remember like studying for boards, and it was like you know lidocaine nausea, like the existing evidence that we have, it's like up at 100 mics per kg per minute.
Yeah.
That's not
Right.
an awake CRI dose, right?
No.
Like, that's an anesthetic dose.
No.
So like, when we have something like sitting in ICU and it's on 20 mics per kg of fentanyl, but then it's also on like 20 mics per kg of lidocaine, and then it's also in there at like 5 to 7 on fentanyl, and they're like, it's nauseous, I'm going to stop the lidocaine, and I'm like, what makes you think that it's the lidocaine? Right? Like I don't know where this like urban legend came from. I've never found a reference. I think it's a very widely accepted thing that quote lidocaine causes nausea. And I've had this battle many times with the criticalist, but I'm like, I think it's probably like the really high doses of opioids we're cranking through them.
The other comment I would add to this discussion is in multiple species, it's been shown to be a prokinetic agent.
Yeah.
Humans, kids.
Or
Yeah.
specifically are the ones where they showed in vitro, not just in vivo, that it caused
Right.
gastrointestinal like prokinesis. So
And so, like, there's a few studies in dogs. There's really not that many. There's one or two that I can think of that I've seen where they looked at it, and the evidence was
it was a little
not.
equivocal for dogs,
Yeah.
right?
And so, like, I'm hard pressed to believe that it's like definitely not a prokinetic, just with the lack of papers that are out there. Like, and it just fascinates me to think that in these species it's a prokinetic agent, but not in dogs. Like, is it a dose? Is it, like, is there something special about
Yeah.
their GI tract that's like different than like a human or a horse? Like,
Well, I
it's a
would
little,
understand if
odd
it
to
was
me.
a different class of animals. Like if you said, no, iguanas, it's not prokinetic, but it is in pigs. I'd be
Yeah,
like, I buy that because mammals, reptiles, like God only knows.
right. Well, also you've got two monogastrics. Humans are monogastric, dogs are monogastrics. Like,
So
it's
I struggle that you couldn't extrapolate per se from another like domestic mammal. Like
yeah. So I do wonder also if we did the right study with the right materials and methods, we would find that's a prokinetic. I mean, I want it to be. I'm like always holding out hope that someone's gonna do the paper and they'd be like, and lidocaine's a prokinetic in dogs. And I'll be like, yeah.
I would love that too, because if I have to read another paper on a local block or on a plasma concentration dose of buprenorphine, I'm going to rip my hair out in clumps. Like, somebody published something different. Like, shout out to anyone listening, like, come up with something else other than local blocks and like pharmacokinetic studies. Like, OMG. But that's another aside. But yeah, I don't know. Like, I think the lidocaine, from my understanding, but like I said, I can no longer remember these references. This shit just pops in my head, and I'm like, was that something Gleed said? Like, like, I don't know anymore. Was it the fourth edition of Lemon Joe's? Was the fifth edition of Lemon Joe's? I don't know anymore. But I do remember being like lidocaine, like the nausea that is.
My question for you
High dose.
is, why the hell do you use lidocaine? I think the lidocaine is the gabapentin of injectable analgesics.
Bailey's
right?
gonna have many.
Come on, that's
it's having a seizure.
Overblown. Lidocaine is a very useful drug.
Is it?
Yes.
Oh,
like, do you think that it has legit analgesia?
I think it provides some degree of analgesia. It's a known MAC reducer. It's an antiarrhythmic drug.
It's a free radical scavenger.
Besides the antiarrhythmic properties,
was it?
Yeah, whatever. So
I'm not like, okay, guys, I'm gonna put the dog on a lidocaine CRI and I'm gonna fucking cure his pain. I'm like, I'm gonna add a lidocaine CRI onto this dog where we're resecting a giant intestinal mass because it's probably full of free radicals and all sorts of nonsense that I don't want in the bloodstream.
Bailey, maybe Beanie doesn't like lidocaine because he went to an Italian dentist. Like, I don't.
Probably. But also, to me, to be honest with you, if I need to, like, unless it's like for antiarrhythmic purposes, a lidocaine CRI, it's a waste of a pump.
Wow.
This is a very strong opinion. I'm so interested.
I'm not in a world where I have to pick and choose. You know what I'm saying? Like, I can have a pump. If I need a pump, it's getting a pump. Like, I can find a pump.
Wait, Beanie, why? What? Why?
Because you have so many other things. You have Dexmed, right? I'd rather do Dexmed before I do lidocaine. I have fentanyl.
Even for somatic pain?
I mean, at that point, I think the ketamine and fentanyl work better for it than lidocaine does.
Okay.
Like, we know that this max sparing effect of lidocaine is so, compared to the others, I'm not saying on its own, right? It has this 30% max sparing effect, right? But like, in reality, the others perform so much better, right? Why do I need to add an extra layer of complication, an extra layer of potential error, right? Unless I can use it only in some species, because, if in cats, you can't, right? So, like, you need to make sure that
you can't, but you have to have really robust gonads, and you have to really watch those doses, right?
Yeah. Like,
I like to make it really complicated so I seem smart.
Oh yeah.
Just kidding.
90% of my job is like,
that was an anesthesia joke.
90% of my job is like, and the alveoluses, and then everyone's eyes immediately just like glaze over, and I'm like, good. We can now move on. Thank you. I bow and then step out of the room.
Yeah, you just say it sound great in the room, and you're like, well, I don't think that's true because of the Meyer-Overton theory, and then you just waltz out. Right? And then everyone just looks stunned, and you're like, see you later, I'm going for coffee.
Yeah.
Like, I don't know. I think we're forcing lidocaine into this great thing where, in reality, I think it has way more uses post-op than intra-op, to be honest with you. Because, there are some limitations to other drugs we use. Like, you can't go as high on your fentanyl post-op because they will get nauseous, right? You can't go as high on your Dexmed because they will be sedated, right? You can go as high on your ketamine CRI because, of course, they're going to be stunned, right? A little bit. And so, like, then adding on the lidocaine at that point has way more sense. But intra-op, to me, it's like, when I came to Oklahoma State, I had one technician that she really loves horses and she's amazing. I love her. But she would do lidocaine pretty often for most horses, right? And I was like, how about we switch it to Dexmed?
Yep.
Tried it the first 2 times, fell in love with it, right? And now she won't do any horse without Dexmed, which I agree with and I love it, right? But in reality,
But here's a question, Beanie. So this is all very interesting. And I feel like everyone from OVC is probably like gonna stop listening to our podcast because
having a
of
seizure,
fun.
yeah.
Like, do you not worry, for example, like let's say you have the patient on fentanyl and ketamine, right? And you got to jack that fentanyl up to like 20, 30. I don't know how high you're comfortable going, but do you not worry at all about, I try to practice opioid sparing anesthesia.
Yeah, no, I agree with you. I don't go as high with that. Like my max is at 12.
Okay.
Right? Like I don't go as high unless I'm dealing with remifentanil.
Okay.
And then we can go, the sky's the limit, right?
If you have a ventilator, just to clarify. Yeah, like wow.
The sky's the limit with remifentanil,
You're not even
right?
drinking tonight, and that was wild.
Yeah.
Don't do that at home.
Or in your practice, at home or in your practice.
Yeah, do not do this. Like, do not rock up tomorrow on all your cat neuters and decide you're going to put them on 50 of remifentanil. Like, don't do that. But yeah, no, I'm very interested.
You totally can.
Lie awake all night.
You totally can, and it's fine.
Shut up. I know you can.
That's the purpose of that drug. The purpose of that drug is to let you have such a ginormous sparing effect and then when you turn it off, it disappears. So like, fuck it. Like in humans, they actually are using it together with this new drug remimazolam for TIVA, and they just do remimazolam and remifentanil. That is it. There is no propofol involved.
Remimazolam. I feel like if I have a kid, I'm gonna call it that.
Well, be on the lookout for our new paper because we just submitted it.
Oh.
Nerd alert.
Anyway.
Thank you for writing a paper on something that doesn't involve buprenorphine plasma concentrations.
But anyway, so we did this max study, and actually the reduction is ginormous. Like if you even just remifentanil alone, a 0.6 mic per kg per minute, there was like an 81% MAC reduction of isoflurane.
In dogs?
In dogs.
What about cats?
We didn't do cats.
I can feel the Davis opioid reluctance about opioids being max sparing bubbling up in Bailey right now, everybody.
And when you had the remimazolam in it, you had a 98% max sparing effect. So it was basically at zero.
Yeah.
Almost.
I was about to say, why bother?
Okay. So just like we're totally derailing GI production.
100%.
So let me just ask, what is the advantage of remifentanil and remimazolam versus propofol?
Because once you turn them off, gone.
I mean, propofol is that slow? What are we talking about?
It's also analgesic. Side note.
Sure. Okay.
Yeah. Right.
But you can get that with other things as well. Just his point about lidocaine, you can get what lidocaine provides with other things. You could with remimazolam and remifentanil, you can do all that with propofol.
And they're both reversible, even if they were to accumulate in a bit. Like remifentanil doesn't really accumulate. Remimazolam.
So remimazolam
it's kind of a weird drug.
Broken down by plasma esterases, then. So it
is.
Okay.
It is. Although, well, I mean, I don't want to spoil this paper that much, but anyway, regardless.
It's okay. No one listens to the podcast anyway.
It doesn't. They don't. It's true. We actually had shit tons of views. That's unbelievable. Like the total views, it's for the last episodes are blown up.
Oh my god, you guys, we're doing it. We're bringing sarcastic anesthesia to the masses.
Yeah.
It's just been limited to the people we work with, and now the whole world gets to enjoy
Well, I
our
also forced my
licensed
family to
flavors.
listen to it. Like, let's not forget them. Like all four of them.
They put it on loop.
And they're like, we have no idea what you're talking about, but it sounds funny.
There's somebody out there that has a phone with Spotify on loop on our podcast
I mean,
forever.
I got email by an Iranian vet who was like, I want to check out your podcast, but I can't necessarily use all these platforms to stream in Iran. And I was like, guys, we're doing this.
Oh
This is
wow.
Hell yeah.
We can figure out a platform for that. Like I don't know if maybe even YouTube. I think they have access to YouTube.
Well,
Probably.
they probably need a VPN to go around it, depending on what countries have what limitations. Like,
Gotcha.
they can't watch it on certain things
Yeah.
in China or what have you. But yeah, VPNs will get you around that in most cases. This has nothing to do with gastroprotectants, by the way.
None of it.
What are your regimens?
What's my
What do you mean?
standard?
What's your like brachycephalic regimen? What's your like? Okay, this patient had this was a TPLO regurg under anesthesia last time. Do we make any modifications to his plan for the future?
Okay, well, I think
he's
this
doing the other side of a few
is-
months later. Like,
yeah, I think a
this
good lead
is a patient who's been intractably vomiting overnight and is getting surgery for a GI foreign body. And oh, by the way, we know he has a stomach that's literally filled with fluid.
Okay, so
No NG2.
very interesting. I'm going to say too that, so first of all, like I always consider what part of the patient population you're in and what the likelihood is that you're going to reflux/regurg, right? So just for the listeners, a little bit of background that reflux and regurg is anywhere from like a quarter to like 2/3 of patients. There, you have some degree of gastric contents entering and exiting the esophagus. And it's because the anesthetic drugs lower esophageal sphincter tone, right? So usually that sphincter is nice and tight unless you have GERD or you're an anesthesiologist. And in which case it's like constant all the time. But what happens, I mean, propofol is probably one of the worst offenders for relaxation of that sphincter. So usually I find if you're going to have like a catastrophic regurgitation event, it's that induction of anesthesia. But yeah, I think it's important to understand that when it's entering and exiting, like, why do you care? Like, why do I care if like acidic gastric contents enter the esophagus? I mean, for me clinically, what I always teach, what my consideration is the vast majority of patients are not going to have serious like morbidity or mortality. Although when, like I said, aspiration happens, it does tend to be a little bit more cataclysmic. But what I think it does is I think it contributes to further reflux, and I think it contributes to low-grade esophagitis. And because our criteria to discharge is the patient is supposed to be eating, if you're nauseous because you're jacked out on opioids and or you're painful and or you've had isoflurane, you basically have a lot of stuff that's causing GI disruption, you're not going to eat. And 9 times out of 10, people are going to say you're painful and they're going to turn the drugs up more and make the situation worse. So what I'm trying to do in these cases is I'm trying to get ahead of the curve from esophagitis. And I'm trying to mitigate the issue so that I can really look to improving discharge time. So I always say, like, what I do on the table affects what's going to happen tomorrow in a week, right? Like, it's not just tube in, tube out, and have a nice day. So for me, one of the things that what I used to do was I was a resident, and they do this in human women. If you're going in for an emergency cesarean and you've not fasted, right? Because like maybe I had an aunt whose water broke right after brunch. Like she basically ate her way into labor, which I was like, props. But if you're not fasted and they do want to do the cesarean, they make you drink sodium citrate, right? Which is a neutralizer. And so if we had known unfasted patients when I was at Cornell, then we would try to have the patient take the sodium citrate. Now, it's messy, it's sticky, it's purple, it smells like grape. And if the dog's a weenus, like trying to get, and it's a huge volume, right? So you're trying to put 40 mils into a Great Dane before a GDV, like it's really challenging. But I also know people used to intentionally induce vomiting in patients to empty the stomach, right? They'd be like, no, give the hydro, make it barf, which puts you again behind that esophagitis curve. And I think precipitates further nausea, right? So, and not a nausea fan. So, generally speaking, I think unless it's a very brief case, I'm going to give both an antacid and sort of like sometimes I pick one because I ran out of the other one, and sometimes the volume is so enormous that it's cost prohibitive to do pantoprazole. Like they'll be like, "Hey Bartel, it's 17 mils of pantoprazole and it's going to cost $100," and I'm like, "Fuck it, give famotidine," right? So smaller volume, more cost effective. So I try to have an antacid on board, and then I try to have some kind of now. Also, listeners, there is a difference between an anti-nausea and an antiemetic. And it's a subtle difference, but it's important to understand that, for example, like ondansetron and maropitant do have that subtle difference. One is an anti-nausea, one's technically an antiemetic. So for the patients who are really like fulminantly clinical nauseous, I'll do both because I find one doesn't control. But
Same.
so most of the time you're getting a gastroprotectant, you're getting the antacid, you're getting an anti-nausea from me. And then I'm trying to minimize the drugs that I'm giving that may contribute to that post-op
Yeah.
problem. But the population also, so the listeners know, like, the longer the anesthetic, the more likely inappropriate fasting times, depending on what species you are. Like if you fast for too long, you increase stomach acid production. So like a 12-hour fast in a dog is highly problematic. If I know you're going to be flipped a billion times, and that is a shout out to the TPLO, where it's like, first we take x-rays and then we flip you for clip and prep, and then we flip you for block, and then we flip you back for surgery, and then the surgeon takes it into dorsal, and then we go back and we flip you for x-ray. And I'm like, flip it a few more times. It's like a roller coaster. I'm like, keep flipping it. I'm like, $50 a flip, guys. That dog's going to regurgitate, right? And it's like big dogs,
100%.
over 40 kilos, over 4 years of age. So if I have like a walking regurgitation poster child, which in my head is a fat Labrador having a TPLO, then I'm going to be more aggressive about it.
Yeah.
That was
No,
a
that's
lot
fair.
of me talking. Beanie.
It's a lot of, but it's a lot of good information, right? Like, so do you do that for every single patient, or is it just specifically the ones that you're more worried about?
Honestly, like if we're going to do something like if we're just going to do like a brief CT under sedation, I'm not going to throw the kettle of gastroprotectants at them. Because I don't think, first of all, we're giving it in a fashion such that it's timely to be efficacious for them.
Right.
But yeah, like I would say,
I think if you want to do something really efficacious, you should suction, right?
oh,
So you
okay.
induce, you intubate, you cuff the tube, suction
Yeah.
the tube, no, the suction the esophagus, right? Mouth
Well,
and esophagus.
lavage.
And before,
Well, there's lavage,
I don't
and
know.
then there's what are you lavaging with? There's sodium bicarbonate.
Well,
People.
Right.
I mean, yeah.
Yeah, that worries me a little bit. Meaning, like, you need to make sure that then you suction the full amount that you put in
Right.
there,
Right.
because
Right. Yeah.
aspirating bicarb sucks way more than aspirating acid.
I'm a tap water person, for the record. I am not a bicarb person.
I'm not a bicarb
Fair. Then
person.
at
I
that
think
point, I'm
putting
fine with
something
it.
in that's that basic is just as caustic as putting in something.
The math is the math. Like water is a neutral pH. Enough water, you will eventually neutralize the stomach acid. They're not
Yeah.
regurgitating gallons of material,
Yeah.
like
Yeah.
their esophagus just can't fit gallons,
Wow.
And like I
Right.
said, I think you putting in something that has like a pH of 13 is just as damaging as pH 2. Like those
Absolutely.
are crazy
Absolutely.
times for me.
But I usually try to suction after intubation
Every
and
case?
before no, but the ones where I'm
Oh,
worried
okay.
about it, right? Rather than like relying on a pharmacologic agent that we do know that it doesn't fix regurgitation, right? Like there is no fix for it.
There is no drug that treats or prevents regurgitation. What you were doing is
Right.
mitigating the symptoms associated.
There was some evidence behind cisapride at some point, maybe.
Have you
Right?
taken a Cisapride? Because be near a toilet
Gross.
when that happens, gentlemen.
Right. So I do agree with the nausea meds. I try to stick with Tiva if I can. Whatever.
Because now I'm going to lie awake all night thinking about lidocaine and fucking pantoprazole. Thanks a lot, baby.
I think we'll find out plenty about lidocaine next month.
Oh.
Dun dun dun.
After this conversation, I gotta know.
Oh, we're coming with the big guns. Oh god, I'm gonna have to study. Yeah. I'm gonna have
Anyway,
to study. I'm gonna have to crack my Lemon Jones 6th edition, which currently is still sitting in its wrapper on my desk.
It's a great version. It's a real upgrade.
I heard really good things about it. I don't have it yet.
Big upgrade. Big upgrade.
But yeah, no, I believe you. It's
We're like Goldilocks and the Three Bears, except with Lemon Jones. It's like one has it and it's read it, one has it and hasn't read it, and one doesn't even fucking have it.
So then what about Serenia? Like what about the new school, if you will? Because Beanie's really like the new school of the three of us.
Okay.
Excuse you.
Just with when you finish. Like you and I are on the tail end of what I think is one school of anesthesia, and Beanie is definitively in the early phases of the slightly newer school of anesthesia.
Fine.
And so
I don't know
all
if we should
those
take it as a compliment or if it's
I want to know about like all the people out there who are like Serenia for anything getting data.
Well, let's not forget how Max
Absolutely
sparing
not.
Serenia is. So you can.
I'm not even gonna go there, but like you know what I'm talking about. There are people who do that, and there are people who I respect who do that, and I understand why they do it. I don't agree with it.
I
Where
don't
are you guys
believe
on it?
in cookbook anesthesia, so there's that. Like, I don't have a
Why-
separate protocol for every single patient. Like, my GDV can change from one day to the next. Like, it's
Right.
not just like I always do this,
Yeah.
and you do
Right.
that. But
why would you need to give, like, so here's my deal, right? Like, why do
Oh,
you
and then
need to give a drug that
and then when
to
are we
try
giving
to
it?
fix a problem you're creating, right? So if you know that you're going to create that problem, just try to avoid creating that problem in the first place, right?
which is
Why the fuck do you
100%
need to give
what you're supposed to
hydromorphone?
do, right? Like, you're supposed to avoid making the patient nauseous. But what if it comes
Right.
in nauseous?
Well, but that's something that we're dealing with afterwards, right? Like, I don't give them Serenia from the get-go if I believe it's if it's not a brachycephalic, if it's not a patient that has a muscle tumor, if it's not a patient that has an history of GERD or something, I'm not gonna give that Serenia randomly, right? Like, I'm not giving random drugs to everybody. It's not like candies, right? Like, this is becoming like the gabapentin of vomiting and nausea here.
No,
Like,
famotidine was already that drug. Like,
For some people, it's
famotidine thunder. Like, famotidine used to be given to every hospitalized patient 100% of the time until the internist lost their marbles. So
for some people, Serenia is like everything gets Serenia. Oh, we're gonna give it opioid. Should we give it Serenia? Like, I don't agree with that. I don't like. And then they're like, oh, well, we're gonna give it hydro. So should we give it Serenia?
you have to give it like a minimum, like an hour, right? Like,
Yeah, that's why I ask every time. I was like, do you have an hour to give the Serenia before you give your hydromorphone? Because if you don't, you're giving a drug for no like you're giving a drug to treat something that you don't know may or may not happen.
yeah,
And so
and I think like I guess you could argue if you gave it at before pre-med or around peri-induction, that it would be more related to recovery. Because don't forget, Beanie, too, we got people out there who don't even have an infusion pump, so TEEF is not an option,
yeah, true.
right? Like,
you can drip propofol.
okay,
They
fancy
you
pants. You
can.
know what I mean?
And that's how they have it for humans, where they have the bottles with the little hang
We
thing.
have it.
Bottles, yeah.
We have it. You just
Yeah.
hang the bottle.
Oh yeah,
Just
Hang the
we
bottle.
just got
spike it.
those. I was like, I want the 100 ml bottles of propofol now for
Just-
TiVo.
Yeah.
If you do a lot of burn work, right? Burn work is always Tiva because they'll never ever put them on an inhalant because they're concerned about smoke inhalation and ARDS and SIRS. So they just hang the 500 ml bottle and spike it directly.
Yeah,
You can hang a 50 ml and do that too. It's just you lose a lot to the line. That's all. But I mean, yeah. I mean, I think that's a nice idea to put out there too and get the cogs turning. But you know that 95% of anesthesia is isoflurane for what we do.
Yeah, but in reality, that's
Right.
yeah. I mean, and I don't wanna go too deep into that. We did a whole episode on Diva. Probably we should revise it at some point, but
already we need to revise our TiVo
Already we
episode.
need
not
to
revise it,
there
but like,
too. And apparently it's ixnay lidocaine. So yeah. Yeah, fuck. I feel like shit. But yeah. No,
Yeah, that's how we're not old school, and here we have Beanie talking about like remifentanil and remimazlam. We're like, what are those?
no, we're not even old school. We're like middle school now, Beanie.
Yeah, that's true.
So we have to have like a young whippersnapper like Beanie in here to like push us back into the light.
That's true.
That's yeah.
such an enlightening role into
No,
this.
no one's using lidocaine anymore, guys. It's fucking it's
No,
too
I mean-
old.
Halothane of injectables, like
Yeah.
like okay. Ooh.
You're still using lidocaine?
That was like it
No,
was like
I mean, I'm not saying that
1982.
you.
Like ugh.
I'm not saying that you shouldn't use it. I'm saying that to me, it's overrated, right? Like we had
Me,
this idea.
it's dead.
We had this idea of wanting to use. I mean, multimodal. It's a great thing. Like I'm all for multimodal anesthesia, multimodal analgesia, and all of that, right? But in reality, especially nowadays where we do more and more blocks, do you really need to have that stupid drug in it? Like, it's such a low max sparing effect that it's not even worth it,
Plus, it reduces
right?
cardiac output.
And it's a
Yeah, it
venodilator, which
causes
means
vasodilation.
will it, it's never going to come out.
Yeah.
Look,
It
none of these
causes vasodilation. I mean, and if somebody was to fuck up the dose, it is toxic, right?
True. True.
Right?
Amy,
And,
honestly,
and
I
so
don't know what OVC is going to do if they hear this podcast. Like they
they're
honestly,
probably
they
gonna
put,
sue
I
me.
would say they put almost 100% of patients on a lidocaine CRI, and they run it between
And that's
100 and
fair.
200 mics per kg per minute, which makes me a
And that's
little
fair.
uncomfy because it exceeds the actual toxic threshold. And I feel like if anything went potty, the regulatory body ain't going to look favorably on that. But, they have their research that shows the animals tolerate it. So, but yeah, no, like it's
No,
it's
and
like
that's fair.
it's the crux of that school of thought.
No, that's fair. But the fact that they tolerate it doesn't mean that it's, any advantages to you, right? Like at the
Oh yeah.
doses we use, because I don't want to put my patients on 100 or 200 mic per kg per minute of lidocaine, right? So at those doses, it may be a different story. But at the doses we use, which is usually around 50 or 30 microgram per kg per minute, I don't think that the advantage I see, besides the antiarrhythmic effect, it's worth it, right?
Bailey and I are
And
going to
so
have
then,
a separate debrief about this. I think
Yeah.
you're rocking our confidence. I was like,
or
I feel
whatever, guys.
shook. I am shook about this lidocaine. Yeah.
I don't know. Yeah.
I mean, this is why we do
It's
this, right? Like, learning ideas,
Yeah.
new tech. I mean, I'm sure
yeah.
I could spend the rest of my career doing exactly the same anesthetic protocol for everything and I'd get away with it. But do I want to be that person? Not really.
Yeah. I mean, if we didn't have new ideas, we would still be stuck at the bag in a barrel, right?
No, we still be putting that little mask where you with the cloth on it and then you just spray the ether on it and then they just take a breath through it, right?
That's the
Or we
thing you
still
do to
use the
horses, right?
hammer.
Or you just go to Italy and they hold you down with a knee.
Yeah.
That was an experience. I have to tell you that
You
was
don't
like,
say. You don't say.
I was like, I'm not even going to get into the PTSD of poor quality anesthesia because that is not the topic tonight. But yeah, summary. I'll give the summary, and the summary is that I think there's a high degree of concern for reflux regurgitation, the adverse events associated with peri-anesthetic drugs. So your nausea, your emesis, your diarrhea, let's not forget. Conversely, your ileus, your inappetence. One, because of the welfare associated, for the patient itself, because it's miserable to be nauseous. And two, the discharge, because that the faster you can discharge patients, the less likely they are to have hospital associated morbidity. So the decisions we make around our protocols affect how those patients go home and when they go home. There's no clear-cut treatment or preventative for regurgitation specifically. The best we can try to do is limit what we do as anesthetists and anesthesiologists to incur it. And then just, think about the drugs and exactly what they're targeting and try to make, informed decisions as opposed to like standardizing just famotidine and Serenia for everything across the board all the time. Did I miss anything? Oh, BD hates
no, I
lidocaine.
think that.
Yeah. Hates it.
BD hates lidocaine, and
Nah.
I'm taking myself off pantoprazole because I don't want to have a kidney transplant. Good times.
Awesome. That I think that summarizes for the evening.
Yeah, and
Well,
don't
thank
go
you.
to an Italian dentist because
Yeah, Dawn.
no, the anesthesiologist carries a big club and speaks softly. Like, no thanks.
Yeah, no. Anyway, thank you everybody for listening. Just for whoever wants to watch this rather than listen it, you can watch us on YouTube. If you didn't know, now you know. Thank you everybody, and I guess we'll see you in the next episode.
Which will be St. Patrick's Day themed and all about Ryan and lidocaine.
Oh yeah.
Yep.
Hell
Yeah.
yeah.
Green
Oh
beer,
yeah.
gentlemen. Green beer.
All right. See ya, guys.
Peace.